My name is Shane Dowling. I'm one of our medical science liaisons here with Aroa Biosurgery. We're going to be talking about cases where Endoform is used globally, and really kind of touch on the global impact that this product has and access from a really powerful technology standpoint. So to give you a little brief kind of introduction here. So the Aroa ECM is what Endoform is made from. It's used in our Endoform products and also our surgical products called Myriad that we'll touch on with one case at the end. So the Aroa ECM is sourced from the forestomach of sheep. And this tissue source previously was discarded, not utilized. The founder and CEO of our company, Brian Ward, really found that this tissue was very regenerative in nature. It had these residual vascular channels after processing that really helps facilitate that rapid cellular infiltration needed for these chronic wounds. So to briefly kind of touch on, our mission as a company, and our focus is unlocking regenerative healing for everybody. Our goal is to be able to provide the technology that we're discussing here to a wide variety of patients, from the United States to Malaysia to Jordan, really giving this advanced technology to as many patients and making it affordable so that they can access these technologies. So really, when we're looking at traditional types of devices utilized in wound care, and we're looking at these grafts or extracellular matrix products, that's one bucket I look at. The other bucket I look at is the reconstituted collagens. And as you can see depicted here, there's quite distinguishing features between these two buckets. When we're looking at extracellular matrix, you're getting a significant amount of proteins and secondary molecules, such as hyaluronic acid, heparan sulfate, laminin, and fibronectin, which are known, proteins known to help with this cellular adhesion to these grafts. All of those secondary proteins are really what distinguish an extracellular matrix from a reconstituted collagen, where you're getting either a type 1 or a type 1 and 3 collagen that's been formulated together to just provide some substance to the wound bed. So the extracellular matrix, you have to think of it more as a scaffold that you're providing to the wound bed. Now, traditionally, these products are very cost prohibitive to use in a global patient population, even in the United States at times. And really what I touched on earlier was really unlocking this technology so that more patients can have access to it. And so far to date, we have Endoform and our Myriad products that are available across the world here in about 21 countries for sale. And to date, we've had about 4.5 million applications. So we're going to touch on cases from all over the globe here, and we'll get into that here shortly. So we're going to start off back in New Zealand, where our company was founded and it is headquartered. So this is a case from one of our clinical specialists, Cecilia, using Endoform antimicrobial in the treatment of a skin tear. So, obviously these patients that develop these are elderly patients. They're more susceptible with their fragile skin. So we've got a 96-year-old female here with some comorbidities, including diabetes, peripheral vascular disease, as well as chronic kidney disease. So starting off with a little bit of a difficult comorbidity set to really heal his wound. So this is a lower extremity wound that we're looking at. It's about a week old, and you can see that bottom insert picture there, kind of at the time of the injury, that hematoma that's present. And then now we're looking at it after it's been lightly addressed, some steri strips. And the key thing about these types of wounds is making sure that it can epithelialize without that skin flap dying. And now that helps prevent a larger wound from occurring. So they elected to trial Endoform antimicrobial directly on top of this wound to just help drive that epithelialization of that crescent part of the wound that's still open. So we'll just kind of step through it here, where you see by week 1, you're seeing that hematoma starting to resolve a bit, and you're actually starting to see some epithelialization at the proximal part of the wound and transitioning down. And you can see some of that residual endoform that's staying right on that bottom portion of the wound. By week 2, after a repeat application, you can see that hematoma is resolved very nicely. You can see a complete epithelialization of that crescent-shaped open wound portion still, that hopefully allowed this patient to spare them from a larger wound and that skin flap from being a more problematic issue. So a small wound to start off with here. Next, we're going to get into something a little bit larger. Staying in New Zealand here, this case is courtesy of one of the wound care nurses, Brown Morgan, using Endoform antimicrobial in a pressure injury. So this is a 55-year-old male, spina bifida, has sensation issues with his lower extremity. He has previously been diverted here, and this wound has been progressing for greater than 6 months. This patient's been inpatient for a little over a year, multiple debridements, as well as a failed flap reconstruction, and now we have this undermining tunneled wound that has failed to heal. So they elected to try Endoform antimicrobial packed into the wound bed, then using a Curlex gauze packing to help really bolster that down to the base of the wound. So stepping through here, week 1, you can see kind of those islands of that yellowish tissue, right? So that's, now that you applied Endoform that week 0, that's going to be this residual Endoform that is incorporating into that wound bed. And here's where we recommend leaving that well-adhered Endoform, reapplying new application at that point. And then again, they pack this wound with Curlex gauze to just really bolster it down. And then by week 2 and week 3, you can see a gradual decreasing size of this wound bed. You're seeing that residual Endoform incorporation by week 2 and 3. And you see a dramatic reduction by week 6, with the wound almost relatively healed. Unfortunately, the patient sustained kind of a tension type issue when they were getting a Hoyer lift out of bed, causing this rip to that area. But knowing they had great success with Endoform antimicrobial, they continued to use that. And you can see at that 12-week image, you've got a fully epithelialized wound base in a great cosmetic outcome where it's not a fibrotic, thick-looking scar. And finally, after 3 years of having this wound, they were able to achieve it with fully epithelialized tissue. So next case here, we're going to go up from New Zealand up to Malaysia here. And this is a case courtesy of Dr. Hari Krishna, using Endoform natural after a second toe resection. So we've got this 67-year-old male here, diabetic, hypertensive, hyperlipidemia, and he had a gangrenous toe that was amputated and then unfortunately developed this surgical wound dehiscent. So now we're about 8 weeks out from this initial procedure with this stalled chronic wound. So here, Dr. Hari Krishna decided to use Endoform natural, apply it into that valley, really making sure it has good contour to the wound base, and then see this patient back weekly for repeat applications. And you can see that progression here by week 2, healthy granulation tissue in that wound base. You can even see that same kind of residual Endoform right in that central island of the wound. And then by week 8, relatively healed wound. With the follow-up at week 10, you see a fully epithelialized wound and a very difficult, challenging wound given its the contour of this. So just a great result here for a patient that was dealing with this wound for about 8 weeks after a surgery that I know he probably didn't want to have. So staying in Malaysia with a very similar type of case here, this is after a third toe amputation with a similar surgical dehiscence from Dr. Hari Krishna. So we've got a 66-year-old male, diabetic, who had this third toe amputation with this resulting wound that failed to heal. So again, we're in this chronic inflamed state, really stalled, no promotion of any healthy tissue. So after a debridement in the office, Endoform was applied to the wound bed and again seen weekly. And this is a really dramatic result where you're seeing by week 1, reduction in the wound size, healthy granulation tissue. And then by week 3, actually, you're able to have complete closure and epithelialization of this wound. So this is a fantastic result for a patient who was dealing with this post-amputation wound for roughly 3 months. So now we're going to jump over to Canada here. And this is a case courtesy of Rosemary Hill, who is a wound care provider. And this is using Endoform antimicrobial in the treatment of a diabetic foot ulcer. So again, 43-year-old male, diabetes, neuropathy, Charcot deformity, hypertension, and he's been dealing with this wound for roughly a year. And about 3 months ago had been diagnosed with osteomyelitis and underwent treatment for that. So now with this resulting wound, they elected to begin treatment with Endoform antimicrobial. So applying Endoform directly to that wound bed weekly, you see by week 5 a dramatic reduction in that total wound area size, roughly 50% if I were to eyeball that. And then progressing through week 6 and week 9, continued wound contracture and epithelialization from that wound perimeter. And by week 11, you're seeing a fully epithelialized wound. A great cosmetic outcome here. You're not seeing a thick scar. You're not seeing very thin tissue. You're seeing robust tissue that's replacing that was damaged beforehand. So you're getting that that endoform to act as a scaffold for that healthy cell to migrate in and generate new soft tissue. All right, so heading down from Canada here, we're going to be down in California. This case is courtesy of Reginald Castling, a nurse practitioner, and this is using Endoform antimicrobial in a chronic wound with an exposed tendon. And that's a pretty common question we get asked: is this product able to be used over exposed tendon? So this case here really highlights that, where you've got a 68-year-old male who has uncontrolled diabetes on hemodialysis for end-stage renal disease, is non-compliant with his medications, likely what leads to these complicated wounds, who has a gangrenous wound to the 4th toe, requires an amputation in its resulting wound. So you've got exposed tendon kind of through that proximal portion of the wound through distal, and after a debridement, they elected to place Endoform antimicrobial down with an antibacterial foam dressing. So stepping through these images here, you've got 1 week out, you're starting to see really no signs of infection, no signs of complications, which is a win. You're getting healthy granulation tissue starting to fill in. Distally there, you really don't see much exposed tendon. Proximally, you still have that exposed tendon. So the Endoform antimicrobial placed into the wound bed, properly hydrated to make sure that the wound is staying hydrated, and then apply that secondary foam dressing. By week 3, that proximal portion of the wound is significantly filled in that depth. It's planar and epithelializing now. That proximal portion still has some exposed tendon. It's a little bit desiccated there, likely due to some moisture management. So ensuring some proper hydration here. They reapplied Endoform. By week 6, you've got very small little islands of that wound to finally epithelialize. So you can continue to apply Endoform directly over those areas, and this wound eventually did go on to heal. So just highlighting that case of Endoform using overexposed tendon. All right, so now going from the West Coast to the East Coast here, we're heading up to upstate New York, case courtesy of Dr. James Stillerman. This is a surgical wound dehiscence after a tumor resection. So this is a 68-year-old male who unfortunately was found to have a malignant melanoma on the back of their left kind of shoulder here. We're looking at, imagine the scapula. So wide excision and then primarily closed. Unfortunately, this wound dehisced, and that's why you see a wound age of about 2 weeks. Patient was on Bactrim for some postoperative prophylaxis, and given that this open wound bed, Dr. Stillerman decided to apply Endoform natural to the base of this wound, and we'll watch it to see how it progresses here. So week 1, you see that second image in. You can see that Endoform is directly in that wound bed. Now, that's as long as it's kind of adhering, we'd recommend leaving that, as we did in those earlier cases when you saw it more in that yellow golden substance. So applying Endoform around the portions of the wound that had Endoform fully incorporate, and then reevaluate at that following week. And you can see that dramatic infill of tissue by week 4. You've got a significant reduction in that wound size. You've got just a small kind of central island of that wound to heal. And you can see some of that residual Endoform that's directly in that track. So that to me doesn't look well adhered. So this would be debrided and then apply new Endoform directly into that wound base to drive that epithelialization. And that's what you see in that week 8 image. You see a fully epithelialized wound, really minimal contracture, and again, a good cosmetic outcome for this patient who had a postoperative complication after a tumor resection. So next, we're going to head out to Las Vegas. This is a case that's really going to highlight the synergistic effects you can get with Endoform and negative pressure wound therapy. This case is courtesy of Dr. Naz Wahab. So we've got a 70-year-old female here who was found down, developed compartment syndrome. We're looking at the inside, the medial compartment that's been filleted open after a fasciotomy. So we've got a good vascular bed, but we've got a significant step off, right? So we're trying to fill in this depth here so that the patient's not left with this big shark bite type lesion in their lower extremity. She's got some comorbidities such as coronary artery disease, peripheral vascular disease, diabetes, and high cholesterol. So Endoform Natural is placed directly into the wound bed. You've got a contact layer that prevents that foam from your negative pressure unit to remove that new tissue that's being built. And then you just apply your negative pressure. So let's see how this progresses. So from week 0 to week 3, we're using negative pressure. You can see a dramatic infill of that wound depth. You're having repeat weekly applications of Endoform. And now at week 3, we're able to discontinue that negative pressure. We've got a healthy wound bed. It's very red, granular tissue. You can see the epithelialization occurring from the perimeter of the wound. And again, we now have a planar wound. We don't have this big shark bite step off that we had originally. This patient could have went back and had a split thickness skin graft if they so desired. They elected to really forego any future surgery and just drive this wound to closure in the outpatient setting. And this is where that continued use of Endoform was really going to help facilitate that. But now you just can use a secondary dressing. And for this, it was just a secondary foam dressing. To week 9, you see a fantastic result, very small portion of the wound to finally epithelialize. And this did occur within the following 2 weeks. So going from week 0 to week 9, you can see just a remarkable improvement in that amount of soft tissue to fill in that void. All right, so now we're going to head to Honduras. And this case is courtesy of Dr. Mark Moline when he went on a mission trip to Honduras and was using Endoform to treat patients there. This is a 44-year-old venous leg ulcer, and that's the age of the wound, not the patient. So I think this is a really, really interesting case of a really chronic wound. So this 61-year-old female, she's actually a wound care provider herself in Honduras. She's been trying a lot of things for this over the course of the decades, really failing to get any improvement. This wound's been stalled in this state. And given that Dr. Mark Moline is familiar with our product, he thought this would be a great technology to add to this wound, as it's been really lacking any advanced wound care products. So we used Endoform antimicrobial in this case for the first month or so, and then transitioned from there to the Endoform Natural. So from week 0 to week 4, you're seeing a reduction in that total wound area size, healthy peri wound. The Endoform you can see actually fully incorporated in that week 4 image. You're just seeing a nice red, healthy granular wound bed. And again, repeat applications weekly based off of how much of that residual Endoform is left. And by week 18, you see this fantastic result. You've got this 44-year-old wound in a 61-year-old wound care provider that's finally going to be able to not have to manage this wound. You've got a great result after a very challenging long time. All right, now going from Honduras, we're going to go over to Brazil. This is a case courtesy of a wound care nurse, Abner Richard, where a patient had a trauma to the lower extremity, resulting in the need for an external fixation device for the fracture, but also a free flap for the open structures that were exposed. But unfortunately, that free flap had a fair bit of necrosis to it. So what you're seeing in the far left here is that necrotic free flap that's now been debrided. So you've got this exposed granular wound bed that is needing some additional wound care products to really drive this to closure. And you can see by the soft tissue envelope, this is a very traumatic lower extremity. It's had some significant trauma to have this resultant injury. So Endoform is applied directly to that wound bed with a contact layer and then a gauze wrap. And at 2.5 weeks, if you can see that central portion of the wound, you're getting that yellow golden substance that we saw earlier in these other cases, right? That's that incorporating residual Endoform. That's left in the wound bed, allowing the body to granulate that tissue in and absorb it, turn it into new tissue. 5.5 weeks, you're seeing that result of what occurs. You've got a dramatic reduction in that total wound area size. You now have this small central wound that has a fair bit of residual Endoform that is left intact. making sure that the wound is staying hydrated, reapply when needed. And by 9.5 weeks, you've got a fully epithelialized wound in this very complex trauma lower extremity that had failed this free flap. So again, it's a nice opportunity to be able to utilize these and save the patient possibly further surgery. All right, so now going from Brazil, we're going to head over to Jordan here, and this is the next two cases are courtesy of Dr. Rami Al Musa, and they involve two types of burns. The first one is a facial burn in a pediatric patient. So this is a 9-month-old child who unfortunately sustained a thermal burn falling into an open flame while in a refugee camp. Given the difficulty to access medical care, he was originally seen via a telehealth visit and then followed up in person about 8 days after. And that's what you're seeing here in that first image. So you've got a significant amount of slough and fibrotic tissue that needs to be debrided. There's some concern for infection as well. And the total area of this wound is roughly 10% in an infant that's less than 1 year old. So this patient was taken for a debridement, and then Endoform Natural was used after that debridement. So you see by that week 2 image now, you've got no sign of infection. You're not concerned, but you can see actually the Endoform that was placed just the week prior. And you can see it was placed on some intact skin, and that's why it looks like it does in the original packaging. So this is it's completely okay if when you apply Endoform, it lays on intact skin. I would usually recommend kind of flapping that portion back into the wound again, just to maximize the amount of product you have directly in that wound bed. This wound was then debrided, and then new Endoform was applied. By week 3, you can see that yellow tissue that's forming there. It has slightly dried out from some moisture management issues. So they elected to just do a thorough debridement, and you can see that really healthy granulation tissue that is in that week 3 post-debridement image in the bottom left there. Fantastic reduction in that wound area size, and then again, very suitable for reapplication of Endoform. And that's what was done from week 3 to week 7, where you see about a 90% reduction in that total wound area size, a very small portion of that wound to finally epithelialize. And by week 8, you've got a fully epithelialized wound, minimal contracture. And again, in the face, this is a very important area to have a minimal contracture for these patients and get these wounds healed as quick as you can, as we know that prolonged wound healing leads to fibrotic scar, and that would be an unfortunate cosmetic outcome. So this next burn is more of a partial thickness burn. Unfortunately, this is a 38-year-old male who sustained a thermal burn from a gas explosion while cooking in a kitchen, and immediately sought care, and then 2 days later was able to get into the hands of Dr. Al Musa. That's what you see pictured right here after a proper debridement from some fibrotic slough tissue. So this wound bed was now prepared for application of Endoform Natural. This was about 4.5% total body surface area, and the patient was in significant pain at this evaluation. So the patient was seen then 2 days later, and then now we're looking at the 4-day image. So a repeat application was done every 2 to 4 days, depending on that residual Endoform, telling the wound how much it needs to be reapplied. You can see that kind of yellowing tissue, right? That's that incorporating Endoform. If it was well adhered, it was left. The wound was then just cleansed, and then you would see a repeat application from day 4 to day 6. And you're seeing, again, those islands of epithelialization occurring. You're seeing some residual Endoform in both of the cheeks, as well as the nares and the forehead. So at this day 6 visit, the patient had a repeat application of Endoform and then was discharged to follow up outpatient. And we're at week 2 now. You can see almost about a 90% epithelialization of the forehead, the cheeks. You see a small area just above the eyebrows there to epithelialize. This wound was maintained with just some sunscreen, and then Endoform was placed just over those areas that were still to epithelialize. So just above the eyebrows and then on the cheeks in a few spots. And by week 3, you've got a completely epithelialized wound. The cheeks and the forehead, you can see some wrinkling of the skin. A fantastic outcome for, again, a facial burn where you really want to be able to have good cosmetic outcome and quick healing. So this patient just made sure to monitor and maintain that hydration with proper sunscreen and protecting this new tissue. And then our last case here is going to combine our two products. So we're going to be looking at our operative product called Myriad Matrix, which is manufactured from the same Aroa ECM we touched on in the beginning. And this is coming in a 3 or a 5-layer version. And then it was also utilized Endoform in the postoperative care to epithelialize this wound before skin grafting. So without giving too much away, we've got all the images here. So we saw that preoperative image in the top left. We've got quite a large pressure injury to this patient's lower extremity we're looking at. They had failed a free flap previously. You see a significant amount of tunneling in that inferior lateral left-hand portion of your screen. And our Myriad Matrix graft, which is more built for these operative procedures, was placed into that tunneled wound and then was placed into the entire wound bed. This was stapled in place and then negative pressure. 10 days later, you see completely granulated in graft. You don't see any residual bits of Myriad graft, and the depth of the wound has significantly filled in. Given the wound size, they elected to reapply our Myriad Matrix graft and then apply the negative pressure. So now 3 weeks from that first application in the far left, you've got a dramatic reduction in the wound size. If you look at the top of that wound bed, this is going to be very similar in appearance to what we were seeing earlier with those residual Endoform cases, but this is the same product, Myriad. Now you see that residual Myriad graft. So that's left in place. Endoform was actually applied from this week 3 to week 6 time frame over the entirety of the wound where there was granulation tissue. Negative pressure was continued all the way up until that 6-week mark where they elected to drive this wound with a split thickness skin graft to really quickly close this wound, and the patient was amenable to it. So 6.5 weeks, this is just about a half week after the graft was applied. You've got 100% graft take, it's well adhered. And at that 9-week mark, you've got a fully epithelialized wound. And looking from where we started to 9 weeks, this is a fantastic outcome for a very chronic pressure injury. So with that, that concludes our tour around the world here of some Endoform cases. I see there are some questions in the chat that we can start to address here.
Shane, a couple of questions to start up front really around residual Endoform. So I guess, in terms of that, perhaps we can just take a minute to explain a little bit about what residual Endoform is, kind of how it provides that visual cheat sheet. And then the questions are, kind of, do you just leave the Endoform in place each time, or do you remove it and add more? And then what kind of wound cleansing would be done with the dressing changes so as not to disturb residual Endoform? So perhaps if we can start a little bit at the beginning and then address those questions towards the end of that.
Yeah, Mike, that's a great question. And I actually think it's kind of easy to think about it as the last part of your question. So you're seeing your patient back after you applied Endoform. You're going to do your wound cleansing with, whatever your preference is, whether it be saline, Vash, whatever solutions your clinic has. I would use that directly over the wound bed. I would not try to kind of pressurize that indirectly into the wound bed, but running it over the wound to cleanse it. If you're going to be soaking it on the wound bed, that would work as well. The residual Endoform should be well adhered to the point where you're not going to be able to remove it by just running these cleansing solutions over top of it. If it does remove easily there, then it means you should just reapply Endoform to that wound bed where it was. Incorporating Endoform will be more tacked down because it's going to have that cellular infiltration. So you're going to be having this connection between the Endoform as well as that granular wound bed. And the more residual Endoform that you see, that wound is now progressed further away from that inflammatory phase. So early on in the wound healing, you're going to see probably less residual Endoform. You're going to see it fully incorporate much quicker. And then as you get into this proliferative phase, especially as you're trying to epithelialize, you're going to see Endoform maintaining that structure to allow that wound to contract. So use that residual Endoform to know how inflamed this wound is and how much to reapply. So the more residual Endoform you see, the repeat applications can be spread out further, and subsequently maybe even those visits could be a little bit spread out further.
Fantastic. Thanks, Shane. I see just one more piece around the residual endoform before we move to some of the other questions. Maybe you want to just elaborate a little bit more about, do you put more endoform over the top of residual endoform?
Yeah. So just so that I'm clear, so if I'm seeing some of those images that we saw earlier, where you saw that it kind of was turning into that yellow, creamy, golden area, that's where I would reapply, especially earlier on in the wound healing time. If I'm starting to see kind of full kind of islands of that yellow tissue, I'd probably wait and see that patient back in a week till I started to see bits of granulation tissue, populating through that graft. And then once you start to see that, you can reapply on top, because you're not only using it to build this granulation tissue, you're also using it to help just drive that epithelialization of the wound.
Fantastic. Thanks, Shane. Some other wonderful questions. So let's move on to some of those. The question here is, besides cost, why not use endoform on most negative pressure wounds?
Yeah, it's a great, I mean, that's something that I can't disagree with. I'm in agreement with you. Anytime I talk with other wound care providers, I tell them that these two therapies are very synergistic, right? You can always use negative pressure because of the benefits that we know it has from both a macro and a micro standpoint. And why not add a scaffold that's going to allow your patient cells to facilitate this this wound to incorporate. So you're using the benefits of negative pressure, but now you have a scaffold for new tissue to actually be generated on top of. So anytime I get someone asking me about negative pressure, I always inquire, are they using anything underneath it? Because it just makes sense to these two products be married so well together.
Absolutely, couldn't agree more with you. I think the synergistic effects are very clear there, and obviously you get to use an advanced extracellular matrix together with negative pressure. The results, bound to be very favorable. So thanks for that, Shane. A couple of questions here combined in one question. What contact layer did you use over Endoform? Then when do you use Endoform natural and Endoform antimicrobial? And lastly, does the Endoform need to stay moist? I can repeat again if you need at the end.
Yeah, so contact layers, really kind of anything that is going to prevent that endoform being removed. So I used to use Adaptic, Xeroform, Mepitel, these silicone layers. You just want a protective layer from the wound bed and the foam that is the negative pressure. So in my clinic, I usually had access to any one of those three. Endoform natural versus Endoform antimicrobial, it's a great question, something we get asked a lot. So the antimicrobial endoform is formulated with ionic silver, and we've been able to show in our preclinical work that it's not cytotoxic to the wound fibroblasts. So I would preferentially tell clinicians to start off with Endoform antimicrobial for the first few weeks, monitor that wound to make sure it's the residual bioburden that is in these contaminated chronic wounds is addressed. And then once I'm content with the nice kind of healthy wound bed that you saw in some of these images, I would transition to the Endoform natural. The nice thing is that these are not priced differently, so you're not having to choose the silver to be more costly. We want to make sure that we're leaving that decision up to the clinician, and this gives you that opportunity. And then the last bit about moisture, that's one of the biggest things I feel like we talk with clinicians about is reassessing the wound and really maintaining that moisture, and making sure that the opposite, making sure that it's not too moist in some VLU. So moisture management is really a big thing for wound healing, as well as how Endoform is going to succeed. So you just want to maintain a nice moist wound environment for the Endoform to incorporate. If it does start to get to a dried phase of the wound, you can have the patient reapply some normal saline to rehydrate that if they're at home in between visits, or if they're seeing you in clinic, you can rehydrate with normal saline as well.
Fantastic. Thanks so much, Shane. That brings an end to the typed questions. I'm just going to pause for a second, see if anybody wants to come off mute and ask that question live, and then we can hand back to you, Shane.
Yeah, this has been great. Looks like we just had Amber wrote in here. Great to hear you've had some good results. Yeah, infected surgical wounds, postoperative dehiscences. that's something that we see a lot of utility into the question earlier. Some of those patients are already coming with a wound back. So really trying to expedite their healing, as they don't want to be experiencing this postoperative complication any more than someone wants to be managing a post-op complication. So this really helps just get that patient to be out of that window of having to manage their wound when you can marry those two together. So I'm glad you've had some good results. All right. Well, if there's no other questions, then I just want to thank everyone for joining us today, for highlighting some really interesting cases of Endoform around the world. And if you have any questions or you want to learn any more about our products, feel free to visit our website, Aroa Biosurgery, and we'd love to have any conversation. So with that, enjoy the rest of WoundCon and have a good evening.